with masking?
Oh, if there's gonna be a lot of people in here, we'll have to wear them, but if it's just us and we're socially
Okay,
apart, then you won't have to.
okay,
I'll leave it up to you. In this building right now,
yeah,
you have to wear them in like the hallways and the common areas. And
Okay.
the desk, we could take them off, so
okay,
that's kind of where things are at right here.
okay. Should I be?
You should not have a.
Oh, sorry, I just meant like, where should I be sitting?
Oh, so we talked about bringing our chairs a little closer, like inside the circle. But
Or just like where, I don't know, trying to think. I have my laptop with me. That's what I'm gonna work off for my notes because I did make some changes last night
okay,
and there wasn't anywhere to print. But I think that's fine, actually.
is it okay if we put you up front and center?
It's fine. Would it look weird to, for the camera to see my screen? Guess that's fine.
Maybe you can kind of like maybe, yeah, set it here.
Oh, I like that.
Yeah, that sounds good.
There's some outlets here.
I was trying to find out, I debated and I talked to them about whether we could do webinar mode, which is like, but I mean, it just means that people online see your presentation and just hear your voice.
Oh, yeah.
So then it's, I don't know how that setup works for her.
Okay.
And I'm not sure with the recording, if that's the way, I feel like that's the way when it records, that's the way it presents.
Right. Yeah, okay, so that'd be
So-
great. I'm gonna put a different chair. Just these cozy chairs look nice.
Should I? Yeah, and maybe, I wonder if I should pull them in.
Well, I think this is fine, actually. This feels good.
Okay.
I just didn't want it to feel like.
Did you want to put these up?
Yeah,
I could do that.
I brought those.
Still here.
Still around.
Well, definitely get eaten at Bartlett.
Okay, good. All right, I'll move that chair back and then. Angie, do you have a count on how many people have registered? That's something that you wouldn't necessarily know. I left my water bottle at the high school last night.
Your awesome water bottle.
It's my emotional support water bottle. Not good. But it's in the car.
Okay, yeah.
Oh, and then Shauna, are you planning to introduce me or would you like me to introduce myself? Okay, great. Thank you.
My notes this time. Without being distracted by. people. Stuff out, I won't have a big crowd, but we're chatty.
What's that?
It was getting chatty before I started last night. And I was
I
like,
feel
oh, I guess I-
so bad. I was one of the chatters. And I was
Oh,
like,
no, no. I mean, that's what's going on.
is this happening? I couldn't have any comments from it. So I was thinking, oh, I don't need a lot. I just need a little bit of caffeine.
So.
You know what?
Hello and welcome to Supporting Grieving Patients with Erin Mathis. My name is Shauna O'Sullivan and I am with the board for the Foundation for End of Life Care. We're supporting this event. It's a volunteer organization and we're here in Juneau to support end of life services, including hospice and bereavement care and community education. Typically, we are a volunteer board and we try to offer the public at least one event per year that is focused on our mission. We also provide support to community organizations through sponsorship and grants to organizations that provide the same services. We have with us Erin Mathis. She's a licensed professional counselor. She holds a degree in art therapy counseling from Marylhurst University. She's worked in the mental health field in Sitka for 17 years, and the last 9 of which is focused on providing education, counseling, and supportive topics ranging from aging, end of life, advanced care, and grief and loss in particular. She likes to host small events that are really about community conversations around grief and loss. And that is her focus today. She's received a master's certificate in thanatology, and that's the study of death, dying, and bereavement from the University of Maryland. And she's certified in thanatology through the Association of Death Education and Counseling. We brought her here today to help our providers just get a little more insight on how to identify signs of grief and maybe how to best support patients who are going through that process. So with that, I'm gonna welcome Erin.
Thanks so much, Shauna. I'm so happy to be here. And thanks for taking your Saturday morning to spend time learning how to support patients who are grieving. So we can move on to the next slide, slide 2. So this is just the CMBE disclosure. I have nothing, no conflicts or affiliations to disclose. So that's there. And then here are the objectives. So after attending this workshop, I'm hoping that participants will be able to develop an understanding of grief as a deeply personal and unique experience that isn't linear and defined by stages, and also identify ways in which grief impacts a patient's domains of functioning, and recognize the variety of factors influencing a patient's experience of grief. And finally, implement a supportive approach for patients presenting in an outpatient setting who have experienced a loss, as well as for family members experiencing acute grief after the death of their loved one in the hospital setting. Thank you. And so to begin any education event or even a grief support meeting, I always share a reading. And I particularly like this one called Broken Hearts. It's by Lang Lee. And you all should have a copy of this. And you're welcome to just follow along as I read, or you can sit back and listen. But I love how this really expresses my personal and professional view on grief. Broken hearts. I know you've lost someone and it hurts. You may have lost them suddenly, unexpectedly, or perhaps you began losing pieces of them until one day there was nothing left. You may have known them all of your life, or you may have barely known them at all. Either way, it is irrelevant. You cannot control the depth of a wound another soul inflicts upon you, which is why I am not here to tell you tomorrow is another day, that the sun will go on shining, or there are plenty of fish in the sea. What I will tell you is this: it's okay to be hurting as much as you are. What you are feeling is not only completely valid, but necessary, because it makes you so much more human. And though I can't promise it will get better anytime soon, I can tell you that it will, eventually. For now, all you can do is take your time. Take all the time you need. So moving into the actual presentation, I like to start off by defining these words: loss, bereavement, grief, and mourning. We use them interchangeably, but they have really specific and different meanings. So we'll start with loss, which is the next slide. So loss is defined as the absence of a person, relationship, role, ability, or attribute. So note that not all losses are death losses. Bereavement is a state that's caused by a loss, such as a death. It means to be torn apart, to have special needs, or to be robbed. And grief is the emotional, physical, social, cognitive, and spiritual response to the loss. So it's the internal meaning that we give to this external event. And mourning is the outward expression of grief, or as Dr. Wolfelt likes to say, grief gone public. So examples of mourning are crying, talking about the person who's died, rituals that we engage in, honoring their memory, acknowledging special anniversary dates. Those are just some of the many examples. So thinking about mourning being a shared social response to loss. And we often don't have a lot of opportunities for mourning. So anytime there's an opportunity to come together and be in that space as a group can be really powerful and helpful. So the truth about grief, this is my slide about the 5 stages of grief. So I know that most everyone is aware of the 5 stages of grief, but I'm curious if anyone, not to call out Dr. Allen, but if anyone knows the history of how they came to be and how they came to be misapplied and misunderstood. You do not have to answer. So the history, you were in a different space yesterday. Yeah, I'm not going to put you on the spot. And in your handout, there's a nice description of this. So if you want to revisit that and look through. But so Elizabeth Kubler-Ross did some important work, but she was working with people who were at their own end of life. So not people who were grieving the death of a loved one, right? And she worked with a very small group of people, and she found some commonalities among this small sample, right? And so she wrote a book or a paper, that became wildly accepted as and misapplied to those who are grieving the death of a loved one. And it makes sense that this happened because I think we're all looking for some predictable formula, some standardized processes that we're going to go through that we can expect. This is what it's going to look like as we grieve. But that isn't true. Grief is highly unique and deeply personal and relies on so many factors that we're really going to get into later on in the presentation. And again, her work is 50 years old, so it makes sense that we would be moving in a different direction and have a different understanding. And I guess my big concern with the fact that it's still so prevalent is that it may put pressure, undue pressure on the person who's grieving to follow this pattern that actually doesn't exist, and they may feel as though they're grieving wrong because they haven't experienced maybe any of these stages, right? Or they've experienced them in a different order, or they've experienced other things that aren't in this list, right? So, and there's still a lot of work to be done around education for mental health providers and physicians and those who work in healthcare as well in understanding this. So that's my piece about the 5 stages. We can move on. So if I had to choose a theory of grief, if I had to, I would choose the dual process model as the best sort of available current theory. So this is my visual interpretation of the dual process model. The infographic that was created, I think in the 90s, is sort of cumbersome, and I don't particularly like the visual aspects of it. So thinking about the dual process model as a healthy theory of grieving that relies on oscillating between a loss side and a new life side. So these 2 doors representing those 2 sides. So on the left, we have the loss side, and this is the space where everything is focused on missing the person who's died, thinking about the person who's died, participating in the grief rituals and the things that I described around mourning, and thinking about life before the loved one died. So living in that world before the death. And then the other side is the adapting, the new normal, the adjusting. This is actually called the restoration side in the model, but I don't like that word because it feels a little, I don't think it's quite as accurate as thinking about adapting, coping, adjusting. I don't love talking about being transformed by grief, especially early on. So anyway, I'll talk more about that later. But on this side, so the new normal side, rebuilding your life on the right side, that's where you're figuring out your new role, creating new traditions, doing new things, having new experiences, new relationships, and adjusting your role within your family and the other family members, their roles with each other. So the idea then is that through our lives, we go back and forth to these sides, right? And it could be moment to moment even, or it could be that we're spending a great deal of time on the left, on the lost side, after the death. And then as time goes on, we spend more time on the right side. But we always go back and forth. And we go back and forth unexpectedly. This came up last night. I mean, grief can hit us out of nowhere. To use another one of Dr. Wolfeld's terms, grief burst. You're heading to the grocery store and something reminds you and you're breaking down and you're on the left side in that moment, in that space, and then you've got to move over to the right side and go in and get your groceries to get stuff for dinner, right? So just thinking about how we go back and forth. So, and that's a healthy experience, and it's normal. It doesn't feel normal, but it is a normal response to grief. Any questions about that? Before I move on, I didn't know if that was kind of a cumbersome explanation. Did that make sense, that oscillation? Okay, great. Okay, so some words of support. So this is where I talk about language and how we talk about grief and keeping these things in mind when we're supporting patients. So we want to avoid terms like recovery or closure or resolution. So thinking about like wrapping this up, right? Because we know that it doesn't get wrapped up, it doesn't end. We want to avoid metaphors such as healing or getting through, getting over, or transformation. And again, this is just my perspective on this. If someone feels at some point in their grief that they have been transformed, that's great, that's wonderful, but that's their perspective. I'm talking about not imposing that on someone. Like, let's try to find the bright side in this. There are oftentimes beautiful things that come out of loss, but early on that can be very hard to identify, and that patient may not be in that space, right? So thinking about that, letting them lead that discussion and identify that for themselves. So we want to use terms like adapting, coping, surviving, and new normal. And this is something I wanted to add in. When we talk about suicide death, we want to avoid using the phrase committed suicide and rather died by suicide. Next slide.
What do you think of succumbed to suicide?
It feels kind of cumbersome
Okay.
and kind of like formal.
I use
But
it
that's,
sometimes because I feel like it's a disease process.
yes. Mhm.
And, you succumb to other things.
Yes, no,
Like,
yeah.
I didn't know how that was felt about in the Greek community.
I mean, I think it's personal. I think died by suicide is kind of the more generally accepted alternative to committed suicide. I've heard all kinds of other options, but that's just more generally accepted as kind of the best option. So some thoughts to keep in mind, just to reiterate a lot of what I've already discussed. There's no right or wrong way to grieve. Grief isn't an illness to be cured. It's not something to fix. Losses aren't to be gotten over, and closure isn't the goal. Grief is not linear. There are no stages, there's no timeline, and grief may last a lifetime. So here are the 5 domains of functioning. I listed these earlier on when I described grief. Grief impacts us not just as a feeling of sadness, but on all levels of self, all of our dimensions and facets. And within each of these 5 domains are normal symptoms of grief. So the first one is kind of the most obvious, is the emotional domain. And I'm curious, what do you think of when you think of emotional and feelings when it comes to experiencing grief? Because there is a list this long that is considered normal. What are some feelings that you immediately think of?
Disconnected,
angry.
So in my case, I could identify a very specific
Yeah.
internal feeling, which we call emotion, but I don't have a description. This is a feeling.
It's a feeling, right? Oh, that's interesting. I appreciate hearing that. So just, you identify it as, you recognize it.
Yeah.
But you don't have a
I've
word for it.
Experienced it many
Yeah.
times.
Yeah.
With starting when my turtle died. When I was
Yeah.
a little kid,
Yeah.
or especially when my dog died when I was a little kid.
And with subsequent losses, then that reemerges and you recognize it. This is how I felt before. Yeah. Yeah. That makes sense.
Is grief a different emotion?
I mean, I love the way Hal described that because yeah, and for him, that's how he perceives it, you know? I would say there's all kinds of, the list is endless, right? I mean, these are normal responses, like however you respond is a normal response. So relief can also be experienced depending on the situation. Guilt, vulnerability, loneliness, fear. Yeah, just so many. What about physical? I think this is the dimension that a lot of us are most familiar with because we get messages from our body that are obvious. We can name them and feel them in a place. What about physical symptoms, I should say?
There's exhaustion.
Yep.
Weight, heaviness.
Inability to take a deep breath.
Breathing, yeah.
Trouble sleeping.
What's that? Trouble sleeping? Yes.
Well, of course, the obvious one is crying. It's
Yep.
physical reaction.
Yep.
Headaches, chest pain.
That's what.
Lack of appetite.
Yes. Yeah. Yeah, so sleep changes and appetite changes are really pretty common. Shared symptoms with the loved one who's died. That. And this is why I often will always recommend that patients have a physical within 6 months or so of a loss, just to address any of the physical symptoms that are emerging and to get reassurance and clarity from their physician about what's going on there. And then what about cognitive?
It is really hard to engage your frontal lobe when you are experiencing grief.
Can you say a little bit more about that? Like, what would that look like for the person?
So for me, that looks like difficulty with tasks that usually are easy.
Yes.
And feeling like it's more difficult to think through things through in a logical manner. A lot of decisions are made from a fear-based place than a
Mhm.
like higher reasoning place.
Yeah. Yeah. So,
I remember just, even now, I think I realize it's been years since my extreme loss and it was just brain fog and not being able to retain anything or learn new things. And I felt like that was gonna last forever. And when you're trying, at that time, trying to onboard a new job and I just felt like I had fear that I would never be able to function again. And it wasn't until I got some of those things back that I realized just how hard that was.
oh, yeah. How impacted it you? Yeah.
And when I think of this, I just think of repetitive thoughts intruding. That you
Yes.
Want to, it's the same things looping.
So glad you brought that up. I didn't have that on my list, but that's something that's very common.
Clouding up my ability to think about to control and focus on one thing.
Yeah, intrusive thoughts, revisiting past moments. So confusion, difficulty making decisions, forgetfulness are really very common, but very upsetting to the person experiencing this, right? Like, what is going on with my brain? And when I've worked with older adults who have lost their longtime spouse, they are at a stage of life where they start to really worry about, am I developing dementia, right? Because that could be more timely. But for anyone experiencing that, it's so disconcerting, right? And again, a normal response that is really not normal. And then what about the spiritual dimension? What sort of things can happen there? How does grief present itself, or how is it expressed? It could be like a deepening of faith or actually a questioning of faith, so. Or a neutral sort of. Yeah,
The
because there's
questioning of faith, I run into that with
Uh-huh.
the seniors.
yeah,
And
me as
they've
well.
been active in the church for years and they're just at a different place and it's too hard to even go. And that's really scares me.
I've seen that too. Yeah, it's really upsetting, right? To have this part of your identity and then have that shift. Just, yeah.
We use the word spiritual in different, in confusing ways. One use of the word is churchiness or something like that, religiosity, but it has a broader meaning. Of course, for people who've been married for a long time, the loss of the spouses leads to the loss of purpose and
Yes, you're on my next slide already. No, that's great. I love that you're saying that. Yeah. And there's the church type of spirituality, but then also like having dreams of your loved one, you know, this connection there. And there are cultures that believe that if you haven't dreamed of your loved one, that means they're unsettled, right? And so there's this eagerness to want to be visited by their loved one in their dreams and know they're okay, right? Or being visited by the deceased through animals or things that happen, you know, these things that you notice and you feel like, oh, this is my person here, you know, with me, right?
I hear that from a lot of my patients.
Yeah.
Is that they either experience interactions with animals especially that are meaningful to them. Or that they see or hear their loved one.
Yes.
Even when they're not asleep. And that,
The auditory.
Yep.
Mhm.
and that is actually comforting.
Yes.
That is not a
It's not
scary
upsetting.
thing.
Yeah, that's interesting. I've heard that too. Yeah, Ashley?
No.
Okay, you're good. Okay, I didn't know if you had a question or a thought.
I had a thought,
Yeah.
this just popped into my mind. I was just at a funeral for my nephew this week. And I had a sister who was gonna have some kind of guided meditation thing that I just dreaded. It was not gonna be a good thing. But she wasn't there, and so somebody else was asked to do it, and so it was just several minutes of silence. I was surprised at how I was able to just bring my dead nephew presence there. I wasn't hearing his voice. I wasn't imagining his face, but just in that moment of silence, it was just really surprising to me. I don't know for everybody with this, but that was so easy to just bring that presence into my consciousness with my eyes closed in that moment. So
With that moment of silence that was shared with this group of people.
Yeah.
I think there's something about that too, being together.
was it? I thought it was closing my eyes and
I
I was blocking my eyes.
But just coming together and creating the space for that, right? You're creating the moment and yeah, going there. Yeah, that's really interesting. And then the final domain would be social. So how does grief show up in our relationships with others? What happens to relationships after a death?
What I see is that sometimes people withdraw from each other. Both the person who is in grieving and the friend who is in grieving.
Yep. It's not uncommon,
It's hard to know what to do for people and you do nothing.
right? And you don't want to mess up, so you retreat. Yeah, you don't know what to say. It's hard to see your friend, your family member hurting. Yeah. You don't want to make things worse, right? So that is common that people don't know what to do, so they don't show up. But sometimes people we don't expect show up, which is also really interesting. You know, it's someone that you maybe don't know as well, but who sort of gets it and is there for you. So I've seen that, I've experienced that quite often. Yeah. And so with social, so the symptoms that relate to the social domain, one thing to note is that the most important thing for a patient is how they perceive their social support, not how you think it should look for them. So if they have a couple of close friends or they're, really close with their neighbor, and you feel like, oh, there should be more people involved, but if that is satisfying to them, that's really all that matters. So it's how they perceive it. That's good to know. Okay, so moving on.
Do you think,
Oh, sorry. I'm always ready to move on. No, it's great.
I just have this thought that our general, like, Western social structure is very disconnected to start with.
Yes.
There's been a lot of writing about social isolation and, especially actually for like middle-aged men, on how little connection to other people they tend to have in Western society. Do you think that's part of why grief processes in our country tend to look a certain way? And a lot of that is like withdrawing from.
Absolutely. And the focus on individualism and doing things on your own, privacy, all of that. I mean, as a parent, I see this so profoundly, that we're expected to really raise our children on our own, and COVID made that so complicated. We just had to do this in this little unit, and that it's not very functional, right? And so we're really siloed, in our little houses. And yeah, I totally agree that if there was a truer sense of community and helping, sharing, and responsibility for each other, this would look a lot different, and grief is absolutely would be impacted in a positive way. So moving on to secondary losses. So this is what Al was hitting on. So with every death loss, secondary or additional losses are guaranteed. So they can't exist without each other, right? So secondary losses happen in 3 areas. So loss of self, loss of security, and loss of meaning. And I don't know what your handout looks like. I can't remember how much detail I shared, but under loss of self is this sense that part of me has died too. So loss of identity and loss of role. So if your spouse has died, are you still married? If your child has died, are you still a parent? I mean, I say yes, but to all of these things, but there's questioning around that, and it looks different socially. And are you still a caregiver, right? If that was a big part of your role, taking care of your loved one. Loss of your primary relationship potentially, and loss of your family structure. So going back to the dual process model, this is all living in that loss space, and then the rebuilding looks like reformulating those things. And so loss of security could be that the world doesn't feel safe anymore, right? Loss of your support system. And these are all potential losses. This is not true for everyone. I should have said that to begin with. But depending on who you've lost and your relationship to that person, just knowing that when you're seeing a patient, if they've lost their spouse or their partner, all of these things or some of these things could be true for them. Yeah.
Just thinking of seniors who.
Yes.
Maybe a little bit more. That in the part of it that is sometimes forgotten, that is our big worry, is financial. I know
Yes.
it's not medical.
Yeah.
But a lot of times the bottom line and the financial and how that really impacts them
Absolutely.
is pretty significant for them to work through.
Absolutely, yes. I don't know if I had just said that, I was just about to say that, but loss of financial stability is on my list. Loss of health, loss of your business, or loss of your home, right? So, because if your finances are impacted in such a way, are you able to continue to pay your mortgage and live in the home that you've shared with someone? And then loss of meaning, so loss of your future together, loss of shared hopes and dreams, loss of the past, which I think is kind of interesting to think about. And I think it's Brene Brown that has this term. She calls it your co-rememberer. So your person who remembers with you, right? And so, in in a couple relationship or close friends, you know, you say like, oh, remember what was that? And you do this thing back and forth and your brains together hold everything, right? And so loss of your co-remember and loss at important milestones to come. So birthdays, graduations, anniversaries, weddings, new babies coming into the world, not being able to share that together. Any thoughts about these secondary losses? I think we know they exist, but we didn't necessarily have a name for them. So it's just a good thing to keep in mind that this person has not just lost their loved one, but potentially so much more.
One thought I had, especially with seniors and their kind of with social and financial position, is now you know your cognitive function might be impaired due to grief.
Right.
Are you making good choices?
You're vulnerable.
Or is this a time that
Yeah.
seniors are way more vulnerable to financial abuse?
Big time.
Like
Absolutely.
family members convincing them to sell their house.
Yes.
They don't need to be.
Downsize. Yeah. Get rid of this.
Very-
Yeah. Yeah.
In our book, we recommend you don't make any important
Yes.
decisions for a year.
Thank you for saying that. I was gonna say, I don't know that I have a specific timeline, but it's, yeah, advisable to not make big decisions like moving
At
or,
least for a year.
yeah. Yeah, right? A year is nothing, right? Drop in the bucket. Yeah.
I know that I've seen a lot of people get pressured by their families,
Mhm.
you know, oh, you're not safe in that environment anymore. And it's either, oh, I'll just move in with you. For this person who has not been stable on their own.
So some taking advantage of that, yeah, yeah. Yeah, we don't want to impose that, you know, urgency or timeline or pressure people to make decisions and leave a space potentially that has deep meaning and still feels as though they're, you know, very connected to their person, right? It should really be on their terms. Okay, so let me just check the time. Okay, yeah, we're doing great. So I mentioned before that I was going to highlight these multitude of factors that influence a person's experience, their personal unique experience of grief. And these are called wordings, mediators, or mourning, so factors that influence grief. And the first one seems really obvious, and I've tried so many times to find a different way to word this, but the first factor is, you know, top of the list is who the person who died was. So their relationship to the bereaved. And when I say relationship, I don't mean like nature or the quality of the relationship, but just who they are to that person in their life. And so the second is the nature of the relationship. So what did the attachment look like? You know, was it a strong, healthy attachment, very secure, or was there conflict? Was it a dependent relationship? You know, the list can go on, but just noting that, okay, so now we're working down the list. So the third factor is the cause of death, right? And so was this a natural death, an accident, a suicide, homicide? That is going to have potentially a different impact for the bereaved. What was the cause of death? Proximity is another thing. So were they close? Were they nearby when the death occurred? Was it sudden or unexpected? Violent or traumatic? Were there multiple losses at the same time? So thinking about, unfortunately, mass shootings, right? Was the death considered preventable? Deaths that are considered preventable are really difficult for the bereaved, right? I mean, that just, the what ifs are so huge in those cases. Ambiguous deaths and stigmatized deaths. We're gonna talk more about ambiguous loss and stigmatized loss later on. So the fourth factor is historical antecedents. So the person's previous losses and how they've coped previously. So that could be a great question, you know, so if you had other losses in your life, how was that for you? What was that like? Their mental health history, big factor. And then any family issues, generational grief, trauma. And then moving on to personality variables, so age is a factor. And grieving style. This is what is now replacing sort of this idea around gender, and that men grieve this way and women grieve that way. Instead, we're going to talk about grieving styles. And so if we think about grieving styles being on a continuum, with intuitive, instrumental being on one side. Intuitive grief looks like lots of emotional expression, wanting to talk about their loved one, just a lot of feelings and expression. And then instrumental is not so much feelings and expression, but the doing and the action, right? And so, you know, traditionally we could think, okay, this is more feminine, this is more masculine, but it's just more, that's not true. There are plenty of women who are much more instrumental. You know, women who start foundations, who become advocates for, you know, the cause of death of their loved one. That's an instrumental way of grieving. So just knowing that about a patient would be helpful. Like where do they fall on this continuum? And then culture is also a big factor. And if we don't know or don't have a sense of how someone's culture influences their grief, we can always ask, and always keep in mind that even within that culture and those rituals and beliefs, this is an individual, right? And so asking them how they, you know, are impacted by grief. When I do intakes for a grief support group, on my intake form, I go over each of the domains of functioning. So how has your loss impacted you emotionally? How has it impacted you physically? And just ask those questions and go through that. I know that physicians and nurses and healthcare providers don't have time to do that. I recognize all of it. This is all like ideal if we have all of this time, right? But it's something, if you are able to know that about the person, could be really helpful in understanding their grief. And then, of course, their personality, under personality variables. Yeah, kind of already said, but social factors. So again, perceived social support. How do they perceive their social support? You know, are they connected to the community? What is their social role involvement and their identity and connection to others? So exploring that. And then finally, any concurrent stressors, which I feel like is kind of in that same world as secondary losses. Like we all have concurrent stressors going on, but they could be really amplified while grieving. So parenting while grieving, incredibly challenging and difficult. Financial challenges and illness are just some examples. I don't have others. Are there any other concurrent stressors that I'm missing? COVID, no.
Well, I was listening to what you're saying, but as I've seen people who died after long illness with a lot of
Right.
care,
Yeah.
just exhausted caregivers.
Yeah.
I'm trying to figure out how that figures in, because that does seem to really affect
Yes.
the survivors.
Good point. Yeah, I think, let's see, where would that go? I think it falls under the nature of the relationship as a caregiver, right?
Mhm.
If your role was to support this person through their end of life, absolutely, that has impact and that is notable. Sure. Yeah, if you weren't involved in that process, that is going to be a different experience.
I feel like I'm doing too much talking here, but actually being present at the time of death.
Yes.
Seems to be, right?
Well, that's why I said proximity, yeah. Well, it's not listed under there. I didn't want to, I don't like text heavy slides.
Yeah.
But being close to the death. Yeah. Either by choice or, you know, just depending on the circumstances.
An interesting thing I've seen for people who did a lot of heavy caregiving near the end of people's lives is when their loved one passes, they get a sense of relief and then they feel guilty about having
Yes.
to sense of relief.
Yeah.
And then trying to help people navigate that set of feelings is really.
Yeah.
So common too.
Very common.
Don't you think there's a different grief and or different guilt that comes from the people who weren't there, who weren't there?
Yes.
There's there's more than one kind of it.
So it's so layered, complex. Yeah.
And that happens a lot in Alaska. because it can't always get there.
Timing, yeah, travel.
And that is a significant guilt that then they have to deal with.
And many of us just live so far from family,
Right.
right? Yeah, and can't be there, or can't be there as a caregiver, not, on a regular basis, kind of come in and go and back and forth.
And there's many people in Alaska that do this all the time.
Yeah.
I've known some that are doing it like for 3 years now,
Yes, yeah,
every month, headed down to help.
it's a lot. Yeah, and it has residual, impact. It doesn't just stop, right? You become a caregiver, it's part of your identity. There's a lot there. So moving on to disenfranchised loss. So this is Dr. Jeanette Doka's work. He coined this term, I guess, is the way to say it. And so losses can be disenfranchised in 4 ways. So society says that the relationship isn't important, so grief is not acknowledged, or the death is stigmatized by society, or the relationship is stigmatized by society, or the loss itself isn't recognized as grief worthy because it's not a death. So the first one, we're thinking of the death of, let's say, an ex-spouse. And I like this example because Dr. Doka was sharing disenfranchised loss with a group of students and explaining how losses become disenfranchised or how they fit in that category. And one of his students raised her hand and said, my ex-husband recently died and I've had a lot of friends saying congratulations, right? And sort of celebrating this. And so she felt like, wait a minute, this was my person for some time. This is the father of my children. And so she didn't feel like she had space to grieve in that way because her loss has been disenfranchised by these friends of hers, right? And that's not uncommon for that to be a tricky spot for someone to be, right? With a past relationship. The death of a coworker, it's like, this is a person you spend a lot of time with, right? They're part of your life, but is that recognized in the same way as someone, in your immediate family? The death of a pet. I think this one is so big and so disenfranchised. Yeah, I think if you relate to that, you relate to it, and it's a big thing. The death of a same-sex partner, miscarriage or stillbirth, the death of a stepchild or step-parent. This is one that I kind of hold close to my heart, and I mentioned my stepfather earlier. But because I do this work and I think about all of these things and how I'll feel and with different losses that will be to come, I can imagine myself telling someone that my stepfather recently died, and that lands different than my father recently died, right? Just because we want to categorize things and understand how the other person feels. And even though this person has been my father since I was 5, when I'm speaking to someone, they may not know that, right? And not recognize it as a serious loss to me. So I just kind of have a heart with that one. The death of a foster child or foster parent, and the death of any other non-blood relatives, so or relationships, I should say. Friends, boyfriends, girlfriends, partners, in-laws, neighbors. All of those relationships are disenfranchised. So the second one is the death is stigmatized by society. So examples of that are death by suicide, death by accidental drug overdose, death by HIV or AIDS, abortion, death by drunk driving, or death of a family member in prison. And again, this is not a comprehensive list, just some examples that Dr. Doka puts out there. You have something?
Yeah, I've been reading a lot lately about parasocial relationships
Mhm.
and how those impact people in terms of grief.
Okay.
Because, as people become more connected to online
Yes.
friends,
Yep.
they develop emotional connections, sometimes in a very one-sided way. And
Yes.
when those people pass away is very harmful. And people don't know how to interact with that grief.
Yes. A great example of a disenfranchised loss, right? Yeah, because that relationship isn't recognized as worthy, or because it was one-sided, or you've never met this person in real life in person, right? How can you have this? Yeah, that's a great example.
I have had patients who have been part of a really strong online community, and then the like hub of that community passed away from a medical condition. It was extremely hard for them because their parents were like, I don't understand.
I don't
why you're
understand,
sad."
right? Oh, right. Yeah, definitely grief worthy, not, but misunderstood or not understood. Yeah. Good examples. So the relationship, number 3 is that the relationship is stigmatized by society. So death of a partner from an affair, death of a same-sex partner, death of a high-risk peer group member, so your drinking buddy or someone that you're using drugs with, right? Still very grief worthy. Number 4, the loss isn't recognized as grief worthy because it's not a death. So examples there are dementia, traumatic brain injury, mental illness, infertility, substance abuse, loss of function. And so I think about loss of function a lot. When I was working some in the hospital, so getting referrals for patients who were due to have an amputation. So at Surgeon Sitka, there wasn't an orthopedic surgeon, or isn't now, I don't think even, but we had one for some time, and then there were just a lot of patients receiving amputations and recovering at the hospital. And so I would be called to meet with them before surgery and then follow up with them after. And for some people, I even continue to work with them as they transitioned home. But it was so wonderful that the care team was recognizing this as a loss that needed grief support or could benefit from grief support. So those are examples of disenfranchised loss and why they're in that category. So next slide. So another type of loss that is notable is ambiguous loss, and there are 2 types. Type 1 is physical absence. So a missing loved one who's never been found, a family member, loved one who's deployed, adoption and immigration. Those are all examples of physical absence. Type 2 is psychological absence. So we talked a little bit about that with dementia, mental illness, brain injury, and chronic illness. A great person to know about with ambiguous loss is have the podcast listed as a resource in your hand up. And it's Pauline Boss. And she's interviewed, does anybody ever listen to On Being with Krista Tippett? That's a great podcast. Yeah, she is some really amazing people on her show. And she has an episode with Pauline Boss, and it's called The Myth of Closure. And Pauline talks a lot about ambiguous loss. Like the way she described it is so beautiful. So all of that is in your recommended resources. I highly recommend listening to that and learning a little bit more about ambiguous loss. Okay, where are we? Go back up. Okay, so moving on to slide 19. Okay, so be yourself, be open, be quiet, be there. So this is something that I came up with, these 4 short, clear, simple statements. And it came out of kind of almost a constant request from people of, what do I do when someone's grieving? How do I show up for them? I don't want to mess up. Things we've already talked about, right? I wanted to create like just a little mantra to keep close. And then under each of these short statements, I have some tips to share. And so when I created this, it was meant to be for more like on a community basis. So friend to friend, your coworker, your neighbor. And so it's not necessarily meant to be for the, the medical setting. But I think there are some things that are applicable. And so I've just pulled those to talk about how those can fit. So be yourself means offering support within the role that you're in. So if you are a healthcare provider, so just knowing that there are boundaries around your role there. So giving support within those parameters and knowing that grief support looks different when you're in different roles, right? how you would care for someone. Be gentle with yourself. I think this goes for anyone, no matter your role, knowing that grief is messy and we all mess up in our attempts to support, and that's okay. And I think you can, in the moment even, just say, well, that's not actually what I meant to say, and backtrack there and move forward, right? People who are grieving give others a lot of grace around us. They recognize that you're trying to be supportive. Knowing that there's no script, so there's no specific words. I think I'm sorry is perfectly fine. I don't know, do people have thoughts about when you've received grief support, things that you appreciate hearing?
I think of examples, but I've never figured out what's the commonality. I think of that often as I'm sitting and trying to write something.
I know.
I can think of examples, somebody who said something to me, but
Yeah.
that was,
It's so personal though, isn't it?
Yeah.
Yeah, it is hard. I mean, I think there's probably more things to maybe not say, and we're all pretty good about not saying those things. But there isn't a script, right? I mean, that's the thing. One of my tips on my sheet that's more community-based, I say, if you don't have words, find somebody else's. There's so many great pieces of writing that can be shared. And I love the idea of sending cards to acknowledge a death and to acknowledge someone's loss. Cards are so nice because they're not super intrusive. It's not you coming up to someone in the grocery store and doing that in that moment. That the person has control over how they receive that, if they look at it again, if they keep it, if it's meaningful, they can revisit it. So if you don't have what you feel are the right words, there's oftentimes words out there that you can use. Again, this isn't fit for the medical setting, but just thinking about how it is tricky to navigate that.
Do you think it would be appropriate if you had a close patient to send a card to their primary family member?
This is so interesting that you asked that. So I brought this up when I worked at Search and was told by the compliance officer, that would be so weird. He was like, no way.
Mhm.
And that didn't feel good. However, if a hospice program is in place and there's, there's bereavement, there's aftercare, right? That's a part of that. But if it is someone, I don't know, that's a good question.
Because I've had families send me cards being like,
Yes.
thank you for caring for that
Yes.
person.
Right. Yeah, that's a really human thing to do, right? I don't know.
that really surprises me that would be a compliance issue. I just think that would be such an expression of warmth.
I know.
and,
This is, patients who've died in
From
the
a physician.
hospital, right? Yeah.
Or a nurse, yeah.
Question, what about if it's a support group? Because, but then you get into the confidentiality of addresses and
Right.
that kind of thing.
If it's coming from the support group for a community member, that is really tricky because if you don't have permission from that person to,
Well, kind of the way we've done it, and
Yeah.
the one support group, I feel it,
yeah,
is let them go ahead and write it, and we can hand it to them maybe at the next meeting or something.
oh, these are people that you're already working with?
Yes.
Oh, yeah, no, that's fine. I'm just thinking back to my work
Yeah, right,
at Braveheart, and the loss in the community.
right.
You can't really reach out, in that way.
That, because that's.
Yeah.
I just find it difficult to navigate sometimes because I often take care of multiple generations of the family.
Yes.
Oh, right.
And, I want to express that.
Yeah. I think it's something to ask and to bring up and see what your fellow physicians are doing and what the boundaries are around that. Because I think it could be deeply meaningful, right? It's just to be seen and to be, cared for in that way. Yeah, because that is such an important relationship, particularly when you're working with a whole family.
I think it just depends. The physicians I used to work for always sent their families cards.
Good, that's good to hear.
Yeah.
That's really good to hear.
That's good to know.
Yeah.
Good.
My father died. There was a This poor guy, he was actually a psychiatry resident. He was doing his rotation in internal medicine. It was really kind of out of place.
Yeah.
But I got this very personal letter from him afterwards.
Wow.
And that was so meaningful. Yeah, I'm stuck on this idea. This is a compliance issue. This is
I
terrible.
know.
This is terrible.
Yes.
That letter I got was, yeah.
It could also be
Yep.
particular to my role, you know, but I wanted to know, because I thought, well, if this isn't happening, let's implement something, because people die at the hospital, you know, and they're not in hospice care, and there isn't bereavement follow-up that's part of this service, this medical service. Sitka does not have hospice, you know, we don't have a true hospice program, so how can we fill in the gaps and, you know, still provide great care? And I did ask about that and was told, no, you know, even the way the medical records work, it's like when that patient's died, it means their chart is like, you know, away now. So, yeah.
It seems so unkind to me because it's not like a person is like,
Right, we know that. Yeah, yeah. Yeah, I agree. Yeah, so something to continue to explore and to, but it sounds like it's been happening, so that's really good to hear. I really appreciate that. Yeah, oh, I was still on this slide, sorry, there's a couple more things to focus on. No, but to move on to be open, so what does that look like? So that's avoiding judgment, recognizing that grief can be kind of odd, you know, in its presentation because it's so unique to each person. Avoid comparing losses, and I would say in sharing about your own loss. Because unless you're asked, you know, have you had this experience? Can you relate to this? But when we're in that moment of being a supportive person to someone who is grieving, regardless of what the environment is or what your role is, I really strongly believe it's about them. And what happens is that our own stuff comes up because one, we don't get a lot of opportunity to talk about it in the first place, so it's right there. And it's like, oh, I can relate to them. I'm going to share this thing. But again, it's like kind of like the tissue thing. It sort of stops their process and then sometimes puts them in the role of caring for you. And that is not at all what you intended, right? You're there to offer condolences and be supportive, but somehow it's shifted. That said, I think it's totally appropriate if we tear up in those moments as a supportive person. I mean, I think it's really hard to not be empathetic and have a response. My tip is just don't like cry harder and louder than the person that you're supporting, right? Like it's okay if you have a tear, right? Right. It's okay. It's really reasonable. And say the deceased's name. There's often a fear that if we bring up this person's loved one, we're going to somehow remind them of their grief and upset them. But what we hear over and over again and what we feel when we're in those situations is that it's a relief. It feels good to talk about your loved one and to have them remembered in that way. And then be quiet. So this is just a nod to listening more than for speaking. I was thinking about this last night and how I never ever talk this much. Like just because I'm doing a training is just nonstop. But when I'm in a supportive role, working with a client or offering group support, it's a lot less words, right? Because I'm holding space and allowing them to speak or not speak and just to be there in that moment with them. And then staying present in the moment. So avoid talking about the future as best you can. I think in a medical scenario that could be a little tricky, but thinking so far ahead about, you know, what are you going to do with your house? Are you, you know, someone's recently lost their pet. Are you going to get another dog? Like just slow down, just slow the roll, be in the moment. One thing at a time. And then a big one with being quiet is avoid trying to fix someone's grief. This is unfixable. Just take that off your shoulder, take it off your chest. You don't have to make this better for them. It's not. And then be there. So offer specific things. I think sometimes people really struggle with identifying their needs. So if you can help them identify what they may need, that could be very helpful and well received. And then following through. So just always following through with what you've said that you would do. So I wonder, should we take a little break or something? I feel like or are people feeling okay to move forward? Okay, all right. Didn't know. This was where we would be showing the Brene Brown, the next, there's a little clip that I had to share, but we're not able to load it. It's 3 minutes long, and I will send the link out to everyone because I think it's definitely worth a view. Okay, so moving more specifically into supporting families after a loss, so more immediately, right? So this is in the hospital setting. So very similar to what we've already covered with the 4 statements of be yourself, be open, be quiet, be there, but with some adding detail. So starting with asking them what they need, again, helping them identify what that might be because they may not have any specific requests, or they might have some. And so, but being shy or unwilling to ask for help. So you have invited the opportunity. What can I help you with? And so an example of how that could look is, what can I do to support you right now? And then giving some examples. I can call their family for you. I can write a letter to your employer, to your school as an excuse, or I can just give you some time, right? So you've given some options. The next tip is to help them connect with those who can best support them. So helping them identify who those people would be. Is there anyone that I can call for you? Who's going to be helpful to you in the days to come? So after you leave here, who are your neighbors, these people that are in your life that would be helpful? How are you planning to get home? Making sure that they have a safe ride home from the hospital. And if they're not able to drive, then arranging that for them. Ask them if they'd like to speak with a doctor, if they've had other questions that have come up. And when you offer this, make sure that there's someone available to come in and talk with them. Ask them if they'd like to speak with a social worker or a bereavement counselor or the pastor. And I was curious at Bartlett, what does that look like? Are there people in those roles? Is there a social worker? And do we know?
There's I know that we have, they offer services that you can, it's like a pamphlet and you can call them
Oh,
and
nice.
they offer services.
They'll respond.
Yes, yeah.
Okay, and that could be sort of in the moment even too.
Yes.
Oh, great. Okay, awesome. Do they have
Yeah,
like a little list of?
Yeah.
Oh, I love that. It's fantastic.
Like the menu of.
Yeah, yeah, of folks that could be helpful. That's great.
Yeah.
Yeah, and being able to see it and read it and hold it in your hand too is really nice and
Yeah.
concrete. I love that. The next step is discussing with them how they'd like to spend time with the deceased. So here, normalizing their preference because each person will have a different response. So some people will want to be with their person and some people will not. And either option is okay. There's no right or wrong. Making the goodbye meaningful by preparing them for what they'll see. So for a lot of people, this is the first time that they've experienced death. And so, sort of anticipating their questions or anticipating what they might not know to know about, that sort of thing. Offer memory making opportunities. So things like a lock of hair or thumbprints or even photos can be really meaningful for families. So just putting that offer out there. Answering questions about what happens next. Again, this could be the first time they're going through this experience, unfamiliar territory. So being open to providing resources and anticipating those questions. And then answering other questions that would arise. So questions about autopsy and medical examination, potentially financial support for funeral services, that sort of thing. And again, I don't know what those resources are at Bartlett or even at Search these days, but there often are supports, particularly around our funeral expenses. and giving them space, but staying nearby. So I like to call this optimal distance. So you're there, but not hovering, reachable. And then let them know who they can contact after they're home. So once they've gone home and they've had some time, so questions may arise then that didn't come up in the moment, clearly, because there's so much going on and so much to process. And so who can they call once they're home? So giving them that contact information. And it sounds like that pamphlet might be a great resource in that regard as well. So reaching back out to the social worker, to the pastor. And then finally, I've said it so many times, but don't judge. Again, everybody responds to grief differently and expresses so uniquely to who they are, and just try not to impose your own thoughts or beliefs onto any of the family members. Okay. Any questions about that? These are listed out with not as much example, but those steps are there, and the source from where I got that information is also highlighted. We'll look back over that. Okay, so this is something that's kind of like bright and hopeful. It's the idea of continuing bonds. So continuing a relationship with the deceased. This has become much more accepted and normalized in the last, however many years. And it acknowledges that grief is ongoing and it isn't something that you get through. It becomes part of review. And it's normal to stay connected with your loved one. And so there's some really interesting research on how your relationship with your loved one evolves, and you relate differently to your loved one at different places in your life. So at 30, 40, 50, and with different milestones as you reach them too. So that will shift and grow. And then, continuing bonds helps to describe these grief-related behaviors. So the things that we do, our daily habits, our private rituals, our conversations that we have with our loved one, visiting the places that we feel closest to them. So these are things that we've all been doing, but this just sort of says like, oh, you're on the right track. This is a really healthy process. So not only are these behaviors normal, but they can help with coping as well. And the phone booth picture is related to another podcast episode that I recommend from This American Life. Again, this is in your handout, so you don't have to write this down. It's called One Last Thing Before I Go, Act One, Really Long Distance. And so I don't know if anyone's heard this episode, but it is about a phone booth in Japan that attracts thousands of people who lost loved ones in the 2011 tsunami and earthquake. And so they go to the phone booth and they call their loved one who has never been recovered or who they know has died. They've had confirmation of that. And they speak to them and they recorded these conversations. I do not recommend listening to this unless you're in a place to cry and to respond and be impacted by it. I sent this link off to a friend and she texted and said, I'm at work and I just listened to this and I cannot leave my office, right? It's really beautifully done, just really special. And I just am so happy that this place exists for people to go to and be there. It's just such a, just a normalized thing that you go to this phone booth and call up your person. Yeah, it's very sweet. And the recordings were made with permission, by the way, just because I did have a little bit of I'm not sure about this. So moving on to what I had planned as an activity, but I don't think that we'll get into it here in this space, but it's something that I highly recommend that really everyone do, regardless of your role professionally, personally. It's a worksheet that's at the back of your handout called Exploring Your Personal Loss Background. And so it's just a list of prompts about exactly what it sounds like. So questions like, what was your first experience with death? What thoughts and feelings did you have at the time? And then it just, moves through other prompts. Questions like, how did your family's treatment of death and grief impact you? So looking back, what shaped your beliefs and your attitudes and things like that about death and loss. Super reflective. It'd be nice to do this maybe with a friend or a colleague and share responses if that feels comfortable. But it is definitely something to set aside time to do. Okay, so I have two, I think two more things to cover, and then some.
For the continuing bonds,
Yeah.
I don't know if this is something you suggest people do, but, and not to be an oversharer like I always am, but, both my grandparents passed away while I was in medical school. And I was not granted time off to go to their funerary services.
You weren't?
Mm-mm.
Oh, gosh.
So,
Oh.
I'm sorry.
It's okay.
I write my grandma letters.
Yeah, yeah. So thinking of that as a type of continuing bonds, yeah. That's really, really unfortunate. I'm so sorry to hear that because.
Sorry, I didn't think I would cry.
We don't know that we're gonna cry. It's okay. Yeah, no, that's, yeah, that's definitely worth tears that you weren't able to do that.
Yeah.
Thank you for sharing that example of continuing bonds and how you were utilizing that.
But anytime anything cool happens, I'm like,
Yeah.
look at what happened. Oh, it's great.
Yeah, you're continuing that relationship as you grow and have life experiences and involving her in that.
I can imagine that early or just childhood experiences with funerals and watching your parents deal with loss of their parent or sibling or whatever would have a big impact on how people view death and the grief process. Is that borne out by studies?
Absolutely, yeah. It's so influential. I mean, these are our guides, right? Our parents, and we're doing what they do, what they're modeling. And that shapes our beliefs and our approaches and has contributed to a lot of the, stigma that exists and, yeah, absolutely.
Sort of.
Yeah, and lack of exposure. So if you're, well, protecting is not the best word. I think that's the intention, is to protect a child from exposure, but, could potentially be a missed opportunity for connection and normalization of.
So I think a lot of us were brought up by people who were, a little more rigid and less open to discussing emotional things
Yes,
in public and even among their families. And that kind of shapes who we are. And it takes time to change all of that. You don't even realize yourself how influenced you were by that upbringing.
absolutely. Yeah, and I think sitting down and doing a reflective activity like that is really illuminating, right? And so thinking about how that impacts our work with patients, particularly, and just how we show up for other people in other ways in our lives. Yeah. Yeah. Any other thoughts about continuing bonds or this activity?
I think it's great. 10 out of 10. Would recommend.
Okay, okay, great, awesome. So moving on, so like I said, I think I have two topic slides and then we'll talk about the resources that I recommend. And then I have a closing reading to share, because I'd like to start with one and close with one. And I'm sorry if that's cheesy, but that's the truth. So we can move past this one. I think it's the next one. Okay, so prolonged grief disorder. I know, bummer. So the DSM-5 was revised and released in March, and it included a new diagnosis for prolonged grief disorder. And everybody kind of knew this was coming. It's been on the table off and on. And it's a pretty divisive topic in the grief world, because a lot of people who do this work feel like it has potential to make something that's very normal and human pathological, becoming a mental illness. The death in this case, the timeline is at least 12 months, has occurred at least 12 months ago, and 12 months is really no time at all. And for children and teens, it's only 6 months. And so you have a copy of the diagnostic criteria. When I read through this, I feel like, okay, what am I missing? You know, this sounds like pretty normal grief to me, but, yeah, this in this way now. A like bright spot, I guess, or positive could be that this does allow for billing for grief therapy, so it gives therapists who have training in grief support and counseling to be able to bill for this and to, you know, but.
There's also an ICD-10 code that's a abnormal grief reaction.
Yes, yep, that's been there for a while, yeah. I know. Yeah, and I don't have the criteria listed for that, but yeah, this is like,
It has like no cultural context whatsoever. It's like anything that's not normal.
right, abnormal, isn't it? Yeah, isn't it? I love the coding.
Excuse me, I was reading these and trying to listen at the same time, and I thought I heard you say this looks like normal grief to you,
I mean, in a lot of ways it does.
even after you.
I think so, potentially, yes. Yeah, the timeline is arbitrary, you know?
They can come and go.
Exactly, right? Yeah, I just think a lot about someone close to me who both parents died, you know, in their childhood, and sort of what that person is dealing with now in her role as a parent. You know, it's intense, right? But is it abnormal or diagnosable? It's a total reasonable response, but that's me. And this is an individual basis, and you know, there's room here, but
Well, yeah, they do give room for, cultural norms.
under this, but not necessarily on the app, on the IC, what is it called? The
The ICD-10
Yes.
coding. So there's one that's a normal grief reaction, that it's literally any grief reaction considered outside of the norm or where you're at.
right. So this is better. This is better because it does acknowledge culture and religious norms, social, all of that. Yeah.
I don't know if this is just me or my preferential way of thinking, but I just figure there's such a big bell curve that, you know, there are people who are experiencing something non-pathologic that could be prolonged, and there's people who don't, and
Right.
all of that is okay.
All of that is okay, yeah. The other bright spot that I recently thought about is that for some people, they do like to have a diagnosis or an explanation. So there could be someone who's seeking support around grief and feeling like, you know, this does not feel right, and I, you know, want an explanation for this. So maybe that is a positive for them, benefit for them. I think about it. Again, just really individualized response, so slide 25, the next one, is about the importance of advanced care planning. I wanted to include this because in my work working with people who are grieving, who recently lost a loved one, and they've had some experience in a hospital that wasn't super positive, or they were in a position to make decisions at end of life that they didn't feel prepared for because they hadn't had the conversations with their loved one. So they were put in a position that was really unsettling for them. They are left with a lot of what ifs. Did I do the right thing? A lot of times those people are really seeking additional support and processing. And so I think that, can't measure this, but I think that advanced care planning can help with that, right? So if those conversations happen and are addressed, you know, on a regular basis. And these people, this couple or these family members really have confidence in advocating for their loved one and know what they would want, that is going to impact their grief differently and potentially, you know, in a helpful way. So I feel strongly about noting this. And so when should patients complete or update an advanced healthcare directive? So the advice is early. So with the onset of adulthood, so whether that be 18 or 21 or whatever, young adulthood, that's the first time. And then it should be updated often. So at each decade minimum, you know, at minimum, the patient turns 30, 40, 50, 60 and on. And then at any major life events. So starting college, getting married or divorced, having children, after a loss, going on a major trip, having surgery. I was really grateful that before I had my shoulder surgery in 2018, that the nurse that I was working with asked me if I had an advanced healthcare directive. I was like, actually, this is my job, and I'm really pleased that you asked me this. I do, it's on file. And anytime there's a new diagnosis of a serious illness. So those are just some times to either update or, if you haven't yet, create one. And I'm curious about what Bartlett uses for advanced directives. Do we know if Bartlett uses the state directive or 5 wishes or?
I'm not sure. I just started here in June,
Okay.
so.
Yeah. Might not
I
have
know
come
5
across.
wishes is pretty well
Is it?
widely talked about.
Okay, that's
These
interesting.
wishes at search all the time.
Okay, Search has their own directive. I created that one.
I don't think anybody where I'm at actually knows about it.
Really? I know, it's such a hard thing to get out, you know? I shouldn't say I created it with a team, but I definitely drove that process because the state document is so long and cumbersome, you know, and so we used, we had a lot of guidance and support around that, but it was meant to be more patient friendly and more approachable than all the legalese that's, you know, in the state document. 16 pages or something, 14 pages. It's a lot of pages. Yeah. So just curious what Bartlett is using, and I'm really pleased to hear Search from your perspective is using, or here in Juneau is using 5 wishes, because that's a great.
That's what I use.
That's a great
I really
document.
review.
Yeah, that's a great document.
Probably check on that, but I thought they had a pamphlet that Bartlett gives out,
Oh, yeah, there's one.
but the counselors would
Okay,
No.
yeah.
But I can supplement that with
Yeah, please.
the conversation about the book that actually Geiger helped write. That comes from the foundation, and I know this was provided to me when my husband was diagnosed with the terminal illness. The Guide for Those You Love When You're Not Here, when you're not there is the second edition. And this was given to me here in Juneau. But what's beautiful about this, it has 2 little workbooks. So if, you know, 2 members of the family can go through it, but it also is very Alaska specific, and we have an author here. Virginia Palmer, I think, also was a major force and an author of this book and designed it after the loss of her husband. But it is guided by Alaska regulations.
We tried to take the very, very Alaska specific stuff out of it. Because the first one definitely referenced Alaska law.
And Juneau specific too, right, wasn't it?
Well, we wrote it for Alaska, but we
Okay,
tried to take that all out. of
Okay.
This, of the green version.
it made it more, yeah.
And I give those out too.
Oh, you do? I was
Yeah.
like,
And what I like to say, I think even with our situation, when we had a terminal illness that was diagnosed with very specific timeline, it was still really hard to sit down and consider it, and especially for some people who are facing that and they're in that stage, which is why it's great to do early and often.
yes.
But I think even encouraging people to use it as a conversation piece, because I know family members may not have documentation, but
Right.
even knowing
Yes.
verbally or, you know, conversationally what somebody wants is a huge burden off your shoulders.
Agreed.
And it does change the way that the choices that are made and then the reflection of those choices.
Yes. 100%. Thank you for saying that. It's very important to acknowledge that even if a piece of paper doesn't exist with those responses, the conversations alone are so meaningful, and put the person in the position of decision making, giving them confidence. They've had that conversation. They know how to move forward, making decisions.
And we do have these are a resource on our website. We do have a purchase price on them, but we're happy to provide them for anyone, and particularly with providers to hand out. And that is at no charge.
It's awesome. It is such a beautiful book. Yeah, and I will say too that if you're working with someone or even completing an advanced directive for yourself, you don't have to answer every question on the document, which I think can be really daunting to people when they're first, looking at this and mulling it over. So just remind people that they don't have to answer every question. So what's there, what they respond to is what would be honored and considered. So that's the guidance. Okay, so the second slide. So recommended resources. So that is in your handout. And when we follow up, we'll email an electronic version of the handout, and you'll just be able to click these resources and be taken right there. So a book that I highly recommend is called Companioning the Bereaved by Dr. Alan Wolfelt. And a website recommendation is called What's Your Grief? And just can't even begin to describe how many resources are available there. You can search by topic, type of loss, or keywords, and articles will pop up. And they offer a lot of great trainings with CEUs and CMEs available as well. So good resource there. And then I talked about the 2 podcasts, and they're linked. So the last slide is our closing reading. Oh, sorry. Yes.
Resources, AARP has quite a bit of information on all of this.
I'd love to
The
add
standard AARP,
Okay.
and it's all divided out in very good
That.
titles of what you're looking at, a whole lot on caregiving too.
Okay, great. I will include that. Just making myself a note. Because I can't change my document. It's uploaded, so I'll add that in. So this is funny. I chose this image because I thought it looked really hopeful, and my husband was like, I don't think so. And then he's like, it's really upsetting. I thought, oh my gosh. And I'd already sent the slideshow, the final version, and I was like, I just can't change this. But to me, this looked really hopeful. Right? And he's like, someone is drowning. And I was like, okay, I'm just gonna not acknowledge it. I'm messed up on this. I really am careful and thought it's a lot of grace here.
Oh, this image gives me anxiety.
So let's not look at that and just listen to the words. Okay, I'm sorry.
I will say that doesn't look like drowning to me.
Okay, so we're on the same page, but he was like, oh, you're gonna need to change that. Cause I quickly went through my slides with him and he was like, yeah, no, I don't think. It's like, we're gonna need to change that. I can't.
To me, somebody's drowning and they're so obsessed with keeping the sprinkler.
I was like, this is so hopeful. Okay, forgive me. Okay, this poem is called The Thing Is, and it's by Ellen Bass. To love life, to love it even when you have no stomach for it, and everything you've held dear crumbles like burnt paper in your hands, your throat filled with the silt of it. When grief sits with you, its tropical heat, thickening the air, heavy as water, more fit for lungs than gills. When grief weights you like your own flesh, only more of it, an obesity of grief. You think, how can a body withstand this? Then you hold life like a face between your palms, a plain face, no charming smile, no violet eyes, and you say, yes, I will take you. I will love you again.
Thank you.
Yeah. Thanks, everyone. I think we have time for questions, but we probably have asked a lot of our questions. I don't know if Gabby has any questions.
She made it.
She put on
the link.
Oh,
Questions?
Well, thanks again, and now
thanks, everyone.
thank you for joining, and we will provide this out site and to the guest list.
Awesome.
You're so, it's fine.
No gun, Aaron.
Oh, don't apologize for being weepy. I got teary reading that, so it's okay.
Thank you, very
I told
well.
Shauna yesterday,
Thank you.
So that is appropriate when you